Last talk of today's CME is by Dr. Rujita Fuke ma'am, Associate Professor, Obstetric and Gynecology. She is talking about abnormal screening test in carcinoma cervix. To chair this session, I invite Dr. Anil Humne sir, Associate Professor, Obstetric and Gynecology Department, and Dr. Aarti Dani ma'am, Associate Professor, Department of Pathology, GMC. Now I hand over the proceeding to the chairpersons.
In the
Hello.
previous contest of, in the reference of previous contest, I want to add the vaccine related, even the vaccine you can give to the male partner, HPV vaccine, so as to reduce the incidence of vaccine is boys. Yes. So that's why the incidence is in European and the Western country it is reduced. So now over to the new speaker. So Rujita Fuke madam, she is a young dynamic gynecologist of this city, and she is holding. I think she is in charge of colposcopy unit of our department. So over to Rujita Fuke madam.
Thank you, sir. Thank you for this kind introduction. And good afternoon, my respected teachers, dear friends, my colleagues, and my dear students. I know I am standing between you and the lunch, but see, once we get abnormal screening reports, we have to keep the lunch aside and think of the strategies or the planning that we have to do if we have this abnormal screening test. And Kamal madam has given me this abnormal screening test report of cervical screening, and then we have to discuss this in detail. So, to begin, I have decided to divide the my topic into the diagnostic part, that is what next after we receive this abnormal screening tests, and the treatment part. So, it will be a lengthy presentation. So, I will go in detail about the colposcopy, and the treatment part I will just finish in a very short panel. On a serious note, why we are discussing this? Because of the increasing problem of carcinoma cervix. I hope you know this person. She's a celebrity. She was a British television star, Jade Goody, and she became famous in one of the big boss sessions, Big Brother sessions. She's a British television star, and she developed this carcinoma cervix at the age of 27, and she died because of the metastatic disease. The problem was she ignored all the 3 warnings she got from her abnormal pap smear reports, right? And on the 4th report, while she was shooting for the big boss in India, right? She was in very much controversy for her racist remark during that episode. She has to return back and undergo the extensive treatment of chemotherapy and radical hysterectomy, but finally the disease was metastatic. She was given only 67% of the survival chance, and she died at the age of 27. And that is why the importance of these abnormal screening tests, and how we should not take these tests lightly, and how we should not ignore these tests. So because of the burden that we have in India, it is the second most commonest cancer, and you can see by this statistics 334 cases per day and 185 deaths. This is important because it affects the women in their prime when they are needed most by their family, and it affects them at this 40 to 64 years of age group. We know a simple pathogen of HPV, 16 and 18, most commonly is responsible for the squamous cell carcinoma. We have 2 types, the low risk and the high risk. The low risk, we know, they are not associated with the carcinomas, but in high risk, and out of which the 16 and 18. 16 is the most carcinogenic, which is responsible for 55 to 60% of the cancer cervix, and second is the HPV 18. But luckily for us, as Madam said, it's a preventable disease because we have a prolonged pre-invasive phase in the form of cervical intraepithelial neoplasia, and the cervix is the exfoliated cells are very much, we can reach to those cells, we can have the screening tests, and we have a decade before it progresses to an invasive cancer. So many things can be done in that period. Now, to understand further, if we get abnormal pap smear or abnormal screening results, what should be done? Let us have a short recap of what normal cervix look like. Cervix, cervix is divided into ectocervix and endocervix. The ectocervix is lined by the squamous epithelium, the endocervix is the columnar epithelium, and it is the junction of the that is squamous and the columnar cells, which is responsible for the origination of cervical cancers. This is the picture of the columnar cells. Columnar cells is a single line cells, and squamous we know as a multi-layered cells. Now, there are some changes going on in the squamocolumnar junction and transformation zone throughout the life of a lady or a girl till she reaches to the age of menopause. We know in the reproductive age group, the squamocolumnar junction, it is well over the ectocervix, the columnar mucosa, it is exposed, right? And it undergoes metaplasia because of the exposure. And as the age progresses, slowly the squamocolumnar junction and this SCJ, it resides inside the endocervical canal, making it difficult for us to do this, to visualize it. Now, what is metaplasia? Metaplasia is the transformation of the columnar cells into the squamous cells because of influence of either infections or the environment. Now, how this metaplasia develops? There is normal cells there. They have, it leads to metaplasia. The next step, if it is not reversed, it leads to dysplasia and ultimately cervical intraepithelial neoplasia, carcinoma in situ, and invasive cancers. So this is how it affects the basal cells, and it starts proliferating and causing the abnormal cells from the basement membrane upwards. And this is how, if it involves the lower 1/3, it is CIN1. It is lower 2/3, it is CIN2. And if whole of this is the involved thickness, it is CIN3. And if it breaches the basement membrane, then it is invasive carcinoma. Mostly 60% of the CIN will regress to normal after 1 year. CIN2 and 3, they have a high risk of developing cancers. Mind where these terminologies have now changed. We do not call it CIN1, CIN2 and CIN3. It's LSIL and HSIL. Low intraepithelial neoplasia, low grade, and it's high grade intraepithelial neoplasia. All CIN2 and 3s have been changed or classified as high grade intraepithelial neoplasia. Now, what is the next step? Whenever we get some abnormal colposcopy screening, most of the conditions, they will require colposcopy. Now the guidelines have changed. We have to 2019 latest guidelines by ASCCP, and according to them, not all cervical screening tests, they require colposcopy. But then, with the exception of few, most of them, they require colposcopy. And colposcopy is the low power binocular microscope, which is we use it for study of the surface epithelium and underlying connective tissues and the vasculature under magnification. So, going back. The importance is, it is complementary as well as superior to cytology. It's simple, non-invasive OPD procedure. It helps in determining the indications of cervical biopsy. It helps in avoiding the traumatic diagnostic procedures like conization. And this colposcopic directed biopsies are the gold standard. It's the gold standard for diagnosis of neoplastic lesions. Now, when we get abnormal cytology reports like ASCUS or LSIs, what should be our approach? And see, according to this table, you will see most of these abnormal screening results, the recommendation is we should go for colposcopic biopsy or random biopsy if no lesion is seen. Random biopsy is colposcopic directed biopsies. Okay, so that is why we'll discuss this colposcopy part in detail. The presence of unhealthy cervix is also one of the indication of colposcopy in addition to the abnormal cytology report and HPV infections. And what do you understand by unhealthy cervix? The history of discharge, bleeding, signs of congestion, bleeds to touch, erosion, prolapse, and miscellaneous like. Relative contraindications are if there is active inflammatory cervicitis, the patient is not cooperative, the patient is postmenopausal who is not estrogen primed, and the heavy menstrual bleeding. These are the relative contraindications. Of course, you can do colposcopy. And these are the factors which are assessed during colposcopy. We see the epithelial contour, we see the color, tone, transformation zone, presence or absence of abnormal vessels, acetic acid and Lugol's iodine. This is how we set up a trolley. Many of the students who are working in colposcopy unit, they are familiar with the things that we are doing there routinely, and this is the standard trolley where we have 3 solutions: acetic acid, normal saline and Lugol's iodine, lots of gauze pieces and the cotton. I do not use the gauze pieces because according to me the surface is rough and they will change the morphology of the surface epithelium. So I preferably use cotton. Then we have endocervical speculum to see the endocervix, and then punch biopsy forceps and Cusco speculum. There is a link of the video, but I don't think it will play. Now, how do we proceed with colposcopy? We explain the procedure and obtain informed consent. We obtain relevant medical history. We rule out pregnancy. We examine vulva first and then insert Cusco speculum, which is a self-retaining speculum, so that we don't need any assistant for this procedure. We start examining the cervix with low power and gradually increase the magnification. We examine the surface epithelium and blood vessels. We firstly use the green filter for the abnormal blood vessels. Now, we apply 5% acetic acid. Now, 5% acetic acid, the concentration is very important, and it is prepared with 95 ml of distilled water with 5 ml of concentrated acetic acid. This is very important. If you change the concentration, the patient might get burns because of the concentrated acetic acid. So it should be applied liberally for 1 minute. You have to continuously go on applying for 1 minute. You have to set the timer, and exactly after 1 minute, you have to inspect the epithelium. Now, some lesions are low threshold, some are high threshold. If you do not get the proper examination, if you do not get proper acetic acid, or if the lesion fades early, you can reapply if required. Search for the lesion, and if the lesion is going into the endocervical canal, you can use endocervical speculum. Entire transformation zones, squamocolumnar junction, and all the borders of the lesion should be entirely seen. Then next step is apply Lugol's and just make a mental mapping of the lesion. Apply Lugol's iodine. Okay, the principle of Lugol's iodine is it transforms the starch. It is rich in starch. Squamous cells are rich in glycogen. And if you apply Lugol's iodine, the glycogen-rich area will turn into dark brown color. Okay, and if the glycogen is depleted because of the abnormal cells, rapidly growing cells, they consume glycogen. The areas, they remain yellowish in color. Then perform endocervical curettage if indicated. Mentally map abnormal areas and perform cervical biopsy. Whenever in doubt, whenever you have suspicion that the lesion is HSIL or is going beyond LSIL, just take random biopsies. And it should be near squamocolumnar junction, at least 3 mm in depth. Now, once you have taken the biopsy, the patient bleeds sometimes. So you have to apply pressure and Monsel's paste to reduce the bleeding. Remove speculum, see vaginal walls, vulva, perineum, perineal area, allow patient to recover, document your findings and explain the findings and give post-procedural instructions. Now, what are the post-procedural instructions? There should be no douching, intercourse or tampons until the spotting subsides. Return, if she has to return if there is foul odor or discharge, pelvic pain or if the bleeding persists. She can be given mild NSAIDs if she has cramping, and follow-up should be after 1 to 3 weeks to discuss the histopathology report and further course of treatment. Then we have take this opportunity and encourage contraception once definitive therapy is completed. Re-emphasize the relationship of cervical dysplasia with smoking, STDs and non-homogamous sexual practices, and stress the lifelong risk of HPV to the patients. Complications can be bleeding. If the bleeding is there, you have to reapply Monsel's solution. You can do packing, but remember to remove the pack before she goes home. Cauterize, you can cauterize the site. You can inject 1 to 2 cc of 2% dignocaine, and rarely a cervical stage you need to be given. Complications can, okay. Now, how it looks, how the cervix looks in normal colposcopic finding. Now, this is how you see. You see a squamous epithelium which is pinkish in color, and you see the columnar epithelium which is velvety, dark red in color. And you can identify original squamocolumnar junction and the new squamocolumnar junction, and the area between original squamocolumnar junction. This is the original squamocolumnar junction which has gone into the ectocervix, and this is the new squamocolumnar junction. The area between this is known as the transformation zone. Okay, and this should be entirely seen while performing the colposcopy. Transformation zone, there are three types. Type 1 is when it is fully seen, type 2 is when it is partially seen, and type 3 is when it is not seen, or some efforts are to be done to visualize it. This is important because these are the standard colposcopic findings we have to document. So these are the three types of transformation zone that you usually see in the colposcopy. Now, how the normal cervix looks like. Normal findings with the 5% acetic acid, the mild metaplastic cells, they can have acetic acid appearance, acetohyte areas we can see with the metaplastic epithelium. But then, that metaplastic epithelium is different from the dysplastic epithelium, and how that I will tell you. Now, I have already told you what happens with the Lugol's iodine. The glycogen depleted cells will will not stain, and they will remain the yellowish in color. This is the normal vascular pattern. These are the different types of vascular pattern, but these are all normal pattern. You can see the network capillaries, you can see the hairpin capillaries, then the regular vascular networks, then this is a normal pattern of the vasculature that you see. Now, this is how we report a colposcopy finding, like whether it is adequate or it is inadequate. Are you able to see the cervix completely, or the vaginal walls are falling and you are not able to retract the vaginal walls properly to see the cervix? Then whether that examination is like satisfactory in terms that you are able to see the transformation zone completely. That is, it should be a type 1 transformation zone. Now, how is the epithelium? How is the columnar epithelium? Are there any metaplastic changes? Are there any dysplastic changes? Then, are there any abnormal blood vessels? What is the finding of acetic acid? What is the finding of after application of the Lugol's iodine? How dense it is? Like, so usually abnormal colposcopic findings will give acetohyte areas, leukoplakia, Lugol's iodine staining, and abnormal vasculature. Now you can see here the difference between the CIN 1, 2, and 3. This is CIN 1 is mild to dense acetohyte lesion, which is well defined. You can just say that is a geographical lesion. It's a map-like lesion that you see, and the lesions is not raised, it's flat. But as you go up, that is CIN 2 and 3, you have a dense white lesions. You can see they are well demarcated, the margins are raised. You can see the surface epithelium is raised. And it's early to appear and late to disappear most of the time. These are the abnormal vasculature pattern that you see here, hairpin capillaries, punctations, mosaic, and the bizarre atypical vessels. They are very characteristics of the, invasive cancers. So now these are few of the images which shows the CIN 1, 2, and 3, and comparison of CIN 1 with the CIN 3, and you can make out the difference between the lesions. This is the abnormal Lugol's iodine uptake. You can see the patchy areas of yellowish part which has not taken the iodine stain. This is a picture of carcinoma in situ. This is a picture of glandular lesions, that is adenocarcinomas, and in this case performing endocervical curettage is must, because the carcinoma arises from the endocervix. The cancer arises from the endocervix. Now some miscellaneous findings like leukoplakia, ectropion. You can see the polyps. You can see the polyps. This is the ectropion, condylomata, and Nabothian cyst. Many a times I have demonstrated this during our colposcopic examinations. This is how a postmenopausal cervix looks. Everything is resided into the endocervical canal, and the infection, that is cervicitis. When we call unsatisfactory colposcopy, when the transformation zone is not seen and lesion is not completely visualized. In this case, a cone biopsy is recommended. We provide our results in the form of SPID score, or we have a Reed index, right? The score between 0 to 2 is considered as low risk or low grade. 3 to 5 is high grade CIN 2, and 6 to 8 is high grade CIN 3. This is how we do. So this is a repeat slide just to show that on all these things, on abnormal cytology reports, we perform colposcopy. And colposcopic directed biopsy, if we get CIN1, CIN2, CIN3, what we should do? CIN1, you can repeat cytology or colposcopy after 1 year or 6 months maybe. CIN2, CIN3, definitely high-grade lesions they are and they need treatment. We have to do excisional procedures in majority of the cases. Adenocarcinoma in situ, you have to do type 3 transformation zone excision, and how this is done, I will come to that. Histological abnormality in adolescents, it should be delayed, in pregnancy, it should be delayed until after the delivery. Just some follow-up post-treatment of all the lesions is by 6 monthly for 2 years by cytology or combined tests. Now, CIN treatment, as I said, it's this observation and co-testing in 1 year. CIN2 or higher, it requires treatment, and treatment is divided into ablation and excision. So if I go into the details of ablative treatments and excisional, it will take another half an hour. So I will just give a passing remark on how this is done. We have 2-3 treatments available as ablative treatment. We have cryotherapy, or we have electrocoagulation, we have thermocoagulation, and we have laser ablation. Right. So the basic principle is we are ablating the lesion. Whatever the abnormal lesion is, we are destroying it without removing it. So we are destroying it either by cryo, or by electro, or by thermo. Right. And excisional treatment is we are actually excising this abnormal area, and we are putting that for histopathological examination to know the border and the invasion and everything. And that is why excisional treatment is reserved for high-grade lesions when we have laser excision, cold knife excisionization, and hysterectomy. Now, what are the ablative criteria? It is done type 1 transformation zone should be fully visible. Lesion involves less than 75% of the transformation zone. It is entirely on the ectocervix, no endocervical invasion, no evidence of invasive cancer. Patient is not pregnant and not menstruating. This is the ablation criteria. Now, these are the different methods. This is cryotherapy, and these are the instruments, cryo gun. And with this gun, we do the ablation, right? This is thermocoagulation. The thermocoagulation, that is, we heat up the tissue at 100 degrees Celsius, and then this is the instrument that is with which we do thermocoagulation, right? And this is how we apply the probe for 1 minute, and then this is the appearance after thermocoagulation. These are the different side effects of mild pain, and I promise to take this lecture detail in some other time, right? The treatment part. So, now, cryotherapy, or with this, what is the post-treatment instructions to the patients? Advice on symptoms to advise the patients to expect some mild cramps or blood-stained watery discharge, use of sanitary pads to prevent secretions, and avoid sexual intercourse for 4 weeks, use of vaginal tampons or douching, and repeat for follow-up examination after 12 months. Now, coming to the LEAP, that is the excisional procedure. And I had this very good video of excisional procedure, but it was 12 minutes video and my laptop was just not cooperating. So I just took few snaps, like the screenshots of the picture, how we drape, how we give anesthesia, local anesthesia, how we put the loop to remove the transformation zone. This is the insulated cuspo speculum. It has a vein to escape the air, and then how that area which we have excised is cauterized with the ball electrode. Now, this is in details about the LEAP procedure. The only contraindication, it should not be performed during pregnancy unless a strong suspicion of cancer arises. Anesthesia, as I told, it's a local anesthesia which is paracervical, 1 centimeter drip into the cervix with the lignocaine. Now, this is the different electrodes that we have with which we do the transformation zone excision. These are the few complications. Intraoperative bleeding can be there, postoperative bleeding can be there, infection, cervical stenosis, and since we are removing the bigger part, and cervical insufficiency. Now, important that I want to say is the different age groups and the different abnormalities and how we proceed. Now, if we have a woman who is more than 25 years with ascus, you have to just wait. Repeat this smear after 1 year. No need to rush to for the treatment. The same thing with the woman who is aged 21 to 24 years with the same finding. Now, younger patients, ideally the screening should not start at the less than 21 years of age. The minimum requirement is 21 years. But if we find such patients, then again we have to do the conservative management. Pregnant patients, again we have to do the conservative management. Only if we have a high-grade lesion, then we have to perform colposcopy. LSIL, again we can wait for 1 year. If the lesion persists, we can do colposcopic biopsy and the further treatment. HSIL, definitely, as I said, you have to go with excisional procedures, no matter what the age or no matter the HPV DNA typing is there. Atypical endometrial cells, you have to combine this procedure with the DNC, that is the endometrial biopsy as well. Just HPV positive and no cytological screening, then we have to combine this HPV positive 16 and 18 along with the cytology, and then if she's 16, 18 positive, then perform colposcopy. 16 and 18 negative, repeat co-testing in 12 months. If cytology is negative, HPV is negative, repeat co-testing in 3 years. If cytology is abnormal with any HPV result, perform colposcopy. If cytology is negative, HPV is positive, then again perform colposcopy. Now, these are the latest recent 2019 ASCP risk-based management, and I'll just tell you because this is important. This is important. The first 4 points are important. They have these are the new additions. Up till now, what we were doing, we were just testing we were doing the screening and we were treating the abnormal results. But it is said that you should, the recommendations should be based on the risk and not the results. Colposcopy can be deferred for certain patients. We can wait, and guidance for expedited treatment is expanded. We have expedited treatment means without doing the colposcopy and colposcopic directed biopsy, right? All positive primary HPV screening tests, regardless of the genotype, should have additional triplex triage testing, as Kamal madam has already told us. Excisional treatment is preferred to ablative treatment for all HSILs, and observation is preferred for CIN1. Histopathology reports are based on lower anogenital squamous terminologies. Continued surveillance for at least 25 years is recommended. This is new. Or you can do after 25 years if the circumstances permit. Then surveillance with cytology alone is acceptable only if HPV is not available. Otherwise, it should always be combined with the HPV, right? And whatever the tests are approved by Food and Drug Administration for HPV should be the standard practice. So this is the highlights of the new guidelines: more frequent surveillance, colposcopy, and treatment. And those at lower risk can defer colposcopy, undergo follow-up. And my talk would be incomplete if I do not express my gratitude to the two great teachers who introduced me to the world of colposcopy. First is my guide and my mentor, Dr. Sabkar madam, who introduced me to this world of colposcopy, who actually inculcated the interest in colposcopy in me, and we have been doing regular colposcopy, running colposcopy clinics, and I hope to percolate that knowledge she has given me to my students, and just not to whom I am guide, but to all the students to whom I am teaching. And the second person is respected Dr. Kamal madam, and you have been very instrumental in keeping up that interest of doing colposcopy and cervical screening in the field of this. And I must say I have done many we were trying to do a project together, and we have done quite this work in cytology since many years. And since she is retiring in this month of October, I would like to pay my gratitude. Ma'am, you were always there, and I hope to continue this association even after your retirement. Thank you so much. Thank you.
Thank you, Rujuta, for your lucid and informative lecture. You nicely explained how to manage and treat when there is something abnormal in a test. Thank you. I just want to ask her one question. If female is sexually active before the age of 21 year, can you do the HPV testing, or it should be done only after 21? Is it recommended or it is not? After 20. So there is no need? Okay.
Treatment part.
Thank you.
Concern with the vaccine, if she
Yes, sir. This is now happening because more and more girls, they are getting vaccinated. So that pool is increasing of the cervical screening, and we are hoping to get the less and less number of patients who will fall into that category of CIN3. So CIN3 is now
so
has
even
been taken
even
as
even
a-
if the HPV is positive, the test is positive, and she is sexually active, and one can recommend the vaccine to its effect because of its effectiveness. Okay.
even after.
We haven't got the long-term results of vaccination. It's still being evaluated whether it has really reduced the incidence of CIN and low-grade and high-grade lesions. It's still not very clear in the literature. They are coming up, and maximum vaccination in boys and girls has been going in Australia. They are very active in this. So everybody is looking up to them for getting the results of the long-term research. So till we have very dogmatic research results, we should continue with screening, vaccination and screening also. And the question that you were asking, Aarti, is that in the NHS UK program, girls, as soon as they are sexually active, they start getting calls for to come and undergo a pap smear.
So coming to the topic, what it is observed in Western country, so because of their massive screening, the incidence of CA cervix comes down. It is reduced. What they may miss that about the endocervical curate. So now because of that they miss the endocervical curate, that adenocarcinoma is on rise. So you have already mentioned the endocervical curate. So one has to give the importance of endocervical curate while dealing with the pap smear.